I invite Dr. Nawal, Dr. Badr, Dr. Hassan to the stage for receiving comments and questions. So, any question, comments? I have a question, Dr. Badr, because you touched the area of my interest, lifestyle modification. So, from your experience, how many of your patients did respond to your advice regarding lifestyle interventions? You could not hear me? Okay. Did you? I'm asking the percentage of your patient which respond significantly to your advice for lifestyle modification intervention.
It's really amazing. I guess many of us have recall this scenario that one of your patients may come to you one day. He will tell you, "Doctor, do you recall that you told me while you are in a hurry a little message? From that time, I have stopped doing so and so, and I have started to do and so and so." It took from us maybe a fraction of just a few seconds. However, it was very effective. Maybe because that patient was willing to change, ready to change, aware about the change, and he is aware how to change. He needs only to be pushed and directed to the way. I guess we need to do it. Many of our patients will respond, really. But how far we do follow the right way of doing the change. If we are failing to do it right, I guess more likely we will fail to get it right at the end. If personally I did it right, I would say most of my cases will succeed.
Great.
But how many of the times I do succeeding in doing it right, I need to study myself.
Okay.
Hello. Thank you very much. If there is a patient with one kidney only, and people always advise him to drink a lot of water, is this good advice or is worsening the kidney more?
Now, if a person discovered incidentally that he's having one kidney and he's living normally without anything, just discovered incidentally, it means that this kidney has been there either from disease or congenitally atrophic, congenitally non-development of the other kidney. This kidney usually is undergoing hyperfiltration, and to keep that kidney going on without any problem, we have to continue keeping that kidney healthy, avoiding all insults, including, of course, dehydration. So advice is good that we advise him as normal to have lots of water. And this advice we tell ourselves and everybody else that we should really not to forget keeping ourselves as hydrated as possible, especially in hot weather. Drinking water, drinking water, drinking water, yes.
Any other question, comment? Dr. Nawal, Dr. Badr, from our observation I think all SHMS members noticed, and all specialty, that most of our patients having hypertension with cardiometabolic risk factors end up on dialysis, end up in open heart surgery or severe retinopathy, in spite of the hugest global health budget, Saudi Arabia. We have many specialties, subspecialty, we have hospital, centers, we have everything. I'm just throwing the question why we have this disastrous project of hypertension and other cardiometabolic risk factor. Do we need them to end in hemodialysis and open heart surgery? And why?
I guess we need all. We need to have primary prevention, secondary prevention, and as well tertiary prevention. We cannot really depend on just one type of prevention to decrease the epidemiology of this huge problem. Unfortunately, the primary prevention is very costly, not in terms only of money. In money, it is much more cost effective than the others, but it is costly because of the way to do it is not just straightforward, and there is nobody to sponsor it from the industry. The industry are marketing, and this is the whole notions. We are consumers all over the world, and one of the products that we are consuming is what the industry, whether they are pharmaceuticals, machines, devices, and so. But for primary prevention, unfortunately, nobody maybe is marketing that.
Okay.
I do agree with Dr. Badr.
Yeah. Could we bring the mic?
السلام عليكم.
Okay, go ahead.
دكتور سام الزهراني جي بي. أنا دكتور سام الزهراني جي بي من الرياض. طبعا أنا جاي هنا على أساس الموضوع من وزارة الصحة، وجانا إلكترونيا، فقلت يعني آجي هنا على طول وأحضر المحاضرة، أحضر المؤتمر هذا اللي هو بخصوص الهايبرتنشن اللي هو مهم جدا، يعني خاصة في الكونتري and worldwide. My question is very simple. I'm as a general practitioner. When a patient comes to me with 140 or 160 over 90 or mild hypertension or hypertension stage 1, how could I give him or what is the best medication or first line medication to give? Because it says here give angiotensin converting enzyme inhibitor. So which one should I choose, or based on what milligram, or based on, يعني I'm a little meticulous about how to choose it, the medication.
Which medication? If we understood your question right, you are asking, you are just hypertensive, and which medication to start with?
Yes.
Is this the question?
Yes.
The first medication to start with is lifestyle modification.
Yes.
And we should liberally prescribe exercise, diet, and life change, and observe the patient for probably 3 months. If that is followed and not successful yet to control blood pressure, then you can use any of the 4 classes of medication as SHMS guidelines said. You could use calcium channel blocker like amlodipine or others, or ACE inhibitor, angiotensin receptor blocker, or diuretics. And any of them have equally sufficient evidence that they reduce the blood pressure and they prevent organ damage.
So there's no first stage, second stage. I'm free to choose. Thank you very much.
Just little as far you are a GP, there is one little thing we need to put an eye on, which is the facilities to follow patient. If I'm having no facilities to follow the patient or to assess as well before starting the medications, it may be unwise to go for those medications where I need to do a renal function afterwards, such as diuretics or ACE or ARBs. However, maybe the only medication left with me to deal with it are the CCB classes, where I don't need really to have a precaution in most of the cases to do a renal function test. This is an issue I do face in many places where I do train physicians and GPs. They will tell me, see, we don't have renal function to do easily and to have the results early. I would tell, so what medication to choose? I'll tell you, then go for a small dose of amlodipine if available. Dr. Uthman. Still, we do have it, unfortunately, in our country.
There are 3 nephrologists here who say you do not need to check renal function when you start ACE or ARB. And the 3 of them are myself, Dr. Nawal, and Dr. Foreh, and Dr. Saleh. So like 4 nephrologists say you don't need to bother about the renal profile. You can do it safely, effectively, and it's clear that if you are highly suspicious for renal artery stenosis, then you need to check for the potassium and the rising creatinine. But in form of magnitude, this is extremely rare. You're talking about less than 1 in 1,000. So at least, whether you consider it evidence or opinion, the 4 nephrologists would say, at least the 3 of them are outstanding nephrologists would say, you do not need to test.
Thank you very much. We have just small certificate and present to our eminent speaker, Dr. Nawal. Dr. Hassan Al-Eid. مصطفى
شكرا. لا
take over